All right, so that's what we're gonna start with is alterations in your skeletal growth and development, okay? And so you probably want to remember this in peds about your embryonic and fetal development of the skeletal system and where it develops from, mostly, mesoderm and your neural crest cells. And the timing of it, and this isn't on your exam, it's just a refresher, okay? So the vertebrae in the axial skeleton begins around week 4, believe it or not, that early. And then we start to see ossification around week 9 in the lower and, thoracic upper lumbar. So that's where the ossification center starts to be. We start to see little limb buds late in week 4, hand pads, okay, around between days 33, 36, fingers, days 41, 43. Crazy how fast all this really develops. Truly amazing. And so, it's amazing that how normal everything is when you consider that it starts from 2, cells that only have half of a, one strand of DNA. It's crazy. Okay, but some of your abnormalities that occur embryonically include syndactylism, so kind of the webbed fingers and toes, okay, or what we call supernumerary digits, or the congenital absence. So you can have an absence of a digit, even absence of a thumb, or you can have extra fingers or toes. Yes, are you raising? No, right, just. And so, sometimes they'll ask the parent, look, do you want us to take this off now? And they'll actually remove the digits, the extra digits, in the peri, part of state. And other times they leave them. But you might see it. As far as bone growth in childhood, it's really pretty rapid. And that the growth plates are what facilitate this bone growth. And so the chondrocytes are they're all responsible for your cartilage synthesis, and that will, your osteoblasts are going to secrete osteoid to help harden the growth and extension at the end points, in the end plates of the bone. And so this continues all the way into puberty. And so during puberty is when the cells stop dividing. The epiphysis and metaphysis fuse, harden. And so you don't see growth plates in adults. Right? And so it's interesting. And when you're in clinic and you're seeing an adolescent child, and you can, especially one that says, wants to be 6 foot tall and is only 5 foot tall. Oh, well, don't worry, your growth plates aren't fused yet. You still got growing to do. And you can tell that by looking at a plain film. This just kind of looks at your growth plate anatomy in detail, which is pretty interesting in and of itself. It shows you where your osteoclasts and osteoblasts are, and where your bone marrow is, where the chondrocytes are, and that metaphyseal region. That's that changeover. That's where a lot of this is happening, right? And so, there are multiple zones of cartilage that allow for the growth to occur. And so this kind of shows you some of those areas here, right? So you can see where vasculature, good nutrition is critically important to support this ongoing growth. The anatomy, this is kind of an interesting picture because it shows you, like they did a coronal section of the femur. And it shows you the different segments of the bone with the femoral head and the femoral neck and your greater trochanter, looking where your bone marrow is and where all these different cells are. It's pretty fascinating, really. Just interesting, Father. Okay. And you can see that if you interrupt your blood flow, even in an adult patient, if you interrupt this blood flow, okay, to the distal parts of the bone, that's when you're gonna result and have areas of osteonecrosis. Okay. This is just looking at it from a different standpoint and showing you the Haversian canals, which are denoted by the H's, okay? And then your E's are your bulk, let's see, an E, it shows some of the Volkmann canals. It's just showing you different areas where your blood vessels traverse. Okay, pretty fascinating, kind of interesting here. And then so what affects the growth at the epiphysis? We talk about trauma and the epiphysis being the weakest part of the growing bone. And now you should be able to see why, if there is an injury in that epiphyseal plate, if it disrupts blood flow, right, then bones distal to it can become develop avascular necrosis. And so you can end up with, you don't have replication, you can end up with premature fusion and uneven length of your joint. Some of the nutritional changes include your vitamin C deficiency, vitamin D. So these two are critically important. We talked about rickets. Vitamin C deficiency is called scurvy. And this is what they figured out with sailors. So vitamin C is actually very necessary for the organic matrix of the bone. And the deficiency of that is going to lead to slowed growth. And then you know what the vitamin D is necessary for. So, and without it, you're not going to have the mineralization of your bones and soft bones. Metabolically, thyroid plays a role. Insulin-like growth factor. So your IGF from your and growth hormone. So liver plays a role, and your insulin as well. Even your androgens are important. So realize that the skull, the fingers, the feet, the jaw, all remain responsive to hormones after puberty. And so this is why even with acromegaly, you can see some of the, where you see the prominent changes. Where do you see them? The hands, the feet, the jaw, the forehead. Right, yes.
Is it also why pregnant women say their feet grow?
I don't have the answer to that. I don't have the answer to that. I always thought it was because of the extra weight and collapse of the arch. That's what I've always thought. But I can't say that I can back that up. But because I've never looked it up. And I'll be honest. I'll be honest. I know that people, anybody who has, once your arch collapses. Yeah, yeah, exactly. Good question. I'll have to look it up now. Okay, so we talked about the extension of the bone. How about growth in bone diameter? So new bone is actually added to the outer cortex as the inner surface gets resorbed. To maintain a specific thickness of the cortex. Why is that important? Nobody wants to take it down.
So it's not too heavy and it can still bend.
Very simple. It is very simple. Thank you, Michelle. It's so the bone is not too heavy. Okay. If you have this really, really dense, big cortex, oh my God, we'd be walking like, I mean, it would be horrible. So the thicker the cortex, that means that's the dense bone. That's the one that has all minerals in it. It's gonna be heavier. And so there's a fine balance between structural stability and being mobile. Okay? So additionally, this kind of give and take, okay, if we we gain on the outside, we're gonna lose a little on the inside. It's gonna help maintain the shape of the bone. It's going to keep them from, it allows movement. It allows bigger cavities for the marrow. As the child grows and needs more, ultimately that gets filled in with that. But, and so much like a tree, you can actually see kind of this concentric rings within the lamellar structure of the bone. And so those osteocytes get buried in there so that they continue to help with maintenance of the health of the bone. And your conversion canals are kind of develop as the calcification occurs. And so that's going to allow the blood vessels to deliver the blood. So what happens in this whole growth process? You know, some of you have had children. Have any of you seen little kids and they're all toed inwards or toed outwards, or, you know, when they're first babies, they're all like externally rotated at the hip. Okay, and you know, that's what babies do, right? So they're all born with a certain laxity of the ligaments. It allows them to pass through the birth canal relatively easily, and you know, it allows for growth and development to occur. That's why I kind of make it funny, and I say, you know, the babies bounce. You know, they're not as rigid as us old people, right? And so they way more flexible. So there's a certain laxity of the ligaments. Anteverted hips, internally rotated tibias, it can be external, but a lot of times they toe in, right? And most of the time, these all resolve during normal growth. Okay? Most of the time. The external torsion, if they are externally rotated tibias, they tend to worsen because of trying to correct it. Because most kids are toed in. And so if the correction is to then align them so that they're not toed out, but that rotation is as they grow for them to correct this way. If they're already externally rotated and it continues that external rotation, then it can make it worse. So toeing in towing out, they have specific names. Okay, and so they do grade this. Did you cover a lot of this in the piece or? Okay, good. And the tibial torsion, again, most of it's internal, it's gonna correct over several years. And so often it's self-correcting, but again, externally, you gotta watch a little bit more carefully. Femoral torsion, you know, the inversion is normal up to 6 years of age. But if it doesn't correct itself, then it can require surgical correction. The external femoral torsion is actually rare, but it typically will self-correct. But these patients can be predisposed to developing the subcapital femoral epiphysis, the slipped capital epiphysis, sorry. And so, or skippy. Love little babies.
Yeah, it is.
It is cute.
I know.
It is just so cute. But anyway, the genuvarum versus genuvalgus. Okay. And again, most of that is going to correct over time. And it's just part of the normal growth and development. As you know, things migrate and bones grow and all of this. So there's a lot of reassurance with parents. And so this kind of shows you the developmental stages and what is a predictable pattern over the course of infancy to childhood. And usually about 6, 7 years old, things are relatively aligned. Okay, some other kind of alterations, pes planus is, you know, flat foot. And this is where essentially they lose the arch in the foot. And so they walk like more pancakes. And it can be acquired if somebody like ruptures their arch or develops laxity, or even just due to obesity and like morbid obesity and weight bearing, collapsing that arch over time. And so something to look out for. I don't know if it still is, but back in the day, you couldn't, when they had the draft in place and all for the military, if you were flat-footed, that was like you were excluded from the military if you were flat-footed. There's two foot types, flexible and rigid. Okay, flexible means if you're non-weight bearing, you can actually see the arch. Once they weight bear, they kind of, you know, pronate and plane out. And so then that's flexible. If it's rigid, there's really no arch. That's your brick or the snow feet. That's my brother's got that. All right, well, let's take a break. I know you can all use it. It can occur. It can just be hereditary. It can just be an aberrancy. Just once in a blue, once in a whatever. Or it can be due to environmental exposures, in utero, like drugs, alcohol, radiation, viruses. We've seen that with the Zika virus. Okay, and so, you know, these things can have detrimental effects during growth and development. And that's all I have to say about that. Okay, fine, move on. Muscular dystrophy, you've learned about that. There are two main types, the Duchenne's and Becker's. Okay, however, there are multiple genetic disorders that have deterioration of your skeletal muscles. Okay? And so you can have mixed muscle cell hypertrophy, atrophy, and necrosis. So it runs the gamut of these. And with necrotic muscle being replaced by fat and connective tissue, so connective tissue is gonna be dense, it's gonna be less flexible, and this can lead to what we call pseudohypertrophy. But it's definitely going to affect your muscle strength, and lead to muscle weakness. And so your Duchenne's is recessive, single gene defect on the X chromosome. So, for the most part, this is predominantly what gender? Male, okay, although there have been spontaneous mutations that occur in some females. Very rare, but it can be a spontaneous mutation. Your Becker is similar, except that it's X-linked recessive, and it occurs later in childhood, and it's slower in progression. And the pathogenesis of Duchenne's has to do with the short arm of the X chromosome, which codes for a protein called dystrophin. Right, and that dystrophin is actually, that protein is located on the inner surface of the sarcolemma, concentrated over your Z-bands. You remember all that sliding filament theory and all the different parts of the muscles. And it will form a linkage between the actin fibers and the external matrix. Okay, when you have defective dystrophin, it's gonna compromise that sarcolemma, which controls your calcium influx into the cells. And so it's gonna have to allow excess calcium in there. And if you remember, when you get to that point of no return with certain levels of calcium in the cell, it essentially becomes that point of no return between cell recovery and cell death. And so that can lead to, once those cells die, they're gonna leak out that creatinine kinase outside the cells, use increased levels of CK. And that's gonna start, once you have that cell death, you can actually start the process of regeneration, and then it's gonna be degeneration, scar tissue, etc. And in this particular case, the rate of degeneration far outweighs the regeneration. And so it's the pendulum is shifted to the degeneration side. And so, when it usually starts to begin after the child's learned to walk. And usually around the age of 2 or 3 is when you're gonna start to see a regression in their ability to walk and etc. This pictorially shows you normal muscle fibers as well as regenerating fibers. Right, and there are alterations in these fibers, and then you actually have overcontracted fibers and then some of the scar tissue that gets the frequency. And so as you lose specific cells and degeneration in these muscle cells and fibers within your muscle bundles, the muscle's gonna get weaker and weaker and weaker and weaker. Okay. Osteogenesis imperfecta, or OI. This is, I've seen one patient who had this. And it's really a devastating disease. It's hereditary, and this has to do with defective synthesis of your type 1 collagen. Usually it's autosomal dominant, although there is a type 3 OI that can be autosomal recessive. And there are your genes that code for your type 1 collagen. And this is important in the development of bones, joints, ears, ligaments, teeth, sclera, skin, all of it. This is why they have the blue sclera. Okay, because of the lack of collagen. Okay, and so, and their bones are very, very, thin. They don't have that fibrous density because of the lack of that collagen. They're prone to fractures. Forget what that movie was. It was a movie it was so good, and it was, and they called the guy Glass or something.
Unbreakable.
What was it called?
Unbreakable.
Unbreakable, yeah. A wild movie, wasn't it? I love that movie. That was a good movie. Anyway, if you ever want to see something, that's what this person had. But short limbs, they often, small head, the face looks kind of triangular. Most of the time they're wheelchair bound, and I mean, literally, they just, anything can break their bones. And they lose their hearing due to otosclerosis. So here are the different types of OI, and it gives you the different inheritance patterns. Okay, and so say something about this slide. Sorry, I don't put notes on my slides, so I'm trying to pull it out of the vault there. Anyway, I would take a look at this, and most of these are, if you see a pattern there, most of them are autosomal dominant. Okay, but there are a couple that are recessive. And so, and one, the infant usually dies with, so, just kind of see a bigger picture there. All right, developmental dysplasia of the hip. It used to be called congenital dislocation of the hip or congenital hip dysplasia. Now it's developmental dysplasia of the hip. Okay, and what test do you use for this? Yep, Watalani and the Harlow maneuvers. Okay, and those are your special tests. And so this has to do with the hips are unstable during development. Okay, and they tend to be malformed, possibly even subluxed, or even dislocated at birth. And so that's why you do those tests. You want to identify them. 1 in 100 will have instability. 1 in 1,000 will actually have the dislocation. The firstborn is more likely to have it in a family, and it tends to affect females more so than males, and the left hip more so than the right hip, and that has to do with the fetal position in utero. And there seems to be it's heredity, but it's also environment, some mechanical factors. They think even the way mom sleeps, and if you put pressure on that particular hip during growth in utero growth and development, anytime if you compromise the blood flow to that area, then it can lead to poor formation. So baby position in utero can play a role. And so this just kind of goes through your normal hip position, as well as when you start to have the laxity and difference between subluxed and dislocated. Right, and so typically the ultrasound is used because at this point it's all cartilage, and because your plain films aren't going to show that ossified femoral head, so you're not really going to see it. So we use ultrasound And because we're looking at the time, like, 4 to 6 months of age. And so you can have those, screening maneuvers, and then you use the ultrasound to follow it up and figure out what's going on. And so, some clues have to include the asymmetric gluteal and thigh folds, which can be a clue as if they're the same, little baby back rolls, they're the same, they look good, that's one thing, but usually it's one more so than the other, often that left side. Clubfoot, this is a very common, about one, it's common enough, 1 to 2 cases per every 1,000 births, in your, when we talk about pediatric orthopedic conditions. And in about half of the cases, they're bilateral, male, more than female. There is a multifactorial inheritance pattern, so it can be associated with chromosomal abnormalities or other congenital syndromes. So if you see a clubfoot, you've got to look for the other things, but most cases essentially just occur because they occur. And so without, repairing this, this can severely affect the child's ability to, function later in life. And, and kids are mean, so they'll get teased and it's not good. A friend of mine does a lot of medical volunteerism and does surgical repair, goes on these, is a surgical PA and goes on these trips to different countries where they will have these clinics and actually repair these, and do, I don't even know how many hundreds of them during a short stay in another country and repair them. Tend to be more, we see them more commonly in other countries. All right, and then the juvenile osteochondroses. So we're moving up from the little babies and children up into the juveniles. And so when we look at these, we're looking at disorders where growth centers in the bones go through a period of degeneration followed by necrosis and then regeneration. There's inactivity in your osteocytes, and then there'll be regeneration leading to deformity. There are 2 groups of these, the true osteonecrotic ones, and then let's see, so the 2 osteonecrotic ones are leg calf herpes disease, which you've learned about, I'm sure, as well as Osgood-Schlatter's disease. There's a few other ones there. And these have to do with osteonecrosis of the apophysis or the axial center. The leg calf herpes, there's a few other ones in that group. And then the Osgood-Schlatter's has to do with ossification of the cartilage tissue. And usually there's some type of trauma that occurs. And so that's where you get that, painful swelling on the anterior tibial tuberosity. Your slip capital femoral ipsis, we talked about that. That's really a problem with the growth plate. So leg calf herpes, we know that that's osteonecrotic. And these patients develop avascular necrosis of the femoral head. And we don't really know the cause, but it can be related to acute trauma. And there does seem to be some correlation with procoagulation parameters in boys. And then if it occurs in girls, they tend to have a worse outcome. And so, there's 4 stages in it. The avascular stage, which lasts about 4 to 6 months. And, you know, how much of the epiphysis involved is gonna, you know, determine the degree of necrosis. There's a revascularization stage that lasts up 1 to 3 years, and then, the reossification stage that occurs, and then there's healed. The Osgood-Schmatters, this is truly due to microfractures where the patella tendon inserts on the tibial tubercle, and it leads to, the microfractures are going to lead to an inflammatory response, and that inflammatory response is going to affect the patellar tendon. So with it, it becomes thickened due to this constant inflammation, and that is what leads to the pain in the front of the knee. We manage that conservatively. The Skippy, also referred to as Foxavera, has to do with the displacement of the femoral head and the epiphysis there on the femoral head, and it goes posteriorly, medially, inferiorly, and the femur rotates. And so it has to do with, oftentimes weight can play a role, because in the majority of the patients are overweight, and or they have this really rapid growth spurt, and it occurs more so in males than females, and about half of them have it happen bilaterally. I had a neighbor's child have it last year and ended up having to have surgery at Children's Hospital. And this kid grew like 16 inches in the course of a summer. Next thing you know, I mean, he's huge. He's over 6 feet tall. And he just had this astronomical growth spurt, and woke up one morning and he was a walk. All right, and I think the last one is scoliosis. So scoliosis is, you know what scoliosis is? This has to do with the deviation of the spine, and so it can be with rotation or without. So it's a curvature of the spine. It can be either in the coronal or frontal plane, and more so we see it in females than males. And it can be restricted to the thoracic spine, or it can involve the entire spine. Most cases, we don't know what causes them, but it can be congenital. It can also be associated with neuromuscular disorders. You can see it develop later in life. So your CP here is cerebral palsy, and the MD is your muscular dystrophy. So when you have other disorders affecting the muscles that support the axial skeleton, it can lead to that curvature. Okay? And so if there are any kind of spinal deformities, so we talked about hemiarthroses, and if you had like an abnormal congenital vertebrae that's only like a half, do you have a hemi vertebrae in there? It can shift the spine and cause curvature because it's not a pure symmetric block of a vertebrae, if you will. And so if it's wedge shaped and diagonal, it's going to clearly cause a curvature of the spine. Leg length differences can also cause it. So congenitally, we look to the 6 to 8 week of embryologic development. Remember, it starts as early as 4 weeks in the lumbar, lower thoracic or early lumbar region. As we get to the 6 to 8 weeks, if there's any kind of disturbance during that time, it can lead to scoliosis. And then the neuromuscular is due to those other diseases. So idiopathically, there are 3 types. Okay, infantile. Okay, and that's if it's manifesting before 3 years of age. It's very, very rare. Juvenile, and 4 to 9 years, again, uncommon. The most common is adolescent. And that's usually after 10 years of age. And it can be until the end of growth, so after puberty. And with this adolescent, they're thinking now that this melatonin receptor 1B gene can actually be playing a susceptibility role. And so that same, we see that in neurofibromatosis type 1 as well, so. We can see this deformity. And that's really all I have for today. Not bad. Oh, no.
Thank you.